The monitor says the baby is in distress. In most cases, that signal is wrong, but surgery happens anyway. Sunday night, at 12:14, a laboring mother grips the bed rail through back pain, her mouth dry, as jagged lines spill from the printer. Staff posture changes before language does. A hand touches her shoulder. She needs one answer: whether her baby is truly losing oxygen, or ordinary labor is being converted into an emergency. Between 2010 and 2018, C-sections reached 21.1% worldwide, a species-level shift toward abdominal surgery. By 2030, the projection is 28.5%. The WHO's population-level benchmark is 10 to 15%. Above that range, higher national rates do not track with lower mortality. The Dominican Republic is at 62.9%, Turkey 58.4%, and the United States 32%. Millions of decisions compressed into minutes. Life-saving when necessary, C-sections can also lengthen recovery, increase postpartum complications, alter later births, and raise infant immune or respiratory risks. One driver sits beside the bed. Continuous electronic fetal monitoring, used in over 85% of American labors. Introduced in the 1960s, it spread before randomized trials showed that it prevented cerebral palsy, the neurological injury it was meant to avert. The problem is whether it distinguishes stress from danger. Imagine judging whether a runner is suffocating by hearing footsteps through a wall while the floor shakes. Cardiotocography, or CTG, does something similar. Ultrasound tracks the fetal heart rate, while a second sensor records uterine contractions. Contractions briefly reduce placental blood flow. Healthy fetuses adapt. Prolonged oxygen loss can make blood dangerously acidic. But CTG never measures oxygen in the brain. It prints indirect patterns shaped by compression, sleep, medication, fever, position, and normal stress. Clinicians classify them visually, with such extreme reader variability that experts dispute identical traces in court. Then the data expose the cost of designing an alarm around the rarest catastrophe. Picture 100 bassinets, each paired with a trace suggesting cerebral palsy. About 99 babies will not develop it. Because the injury is rare and the warning nonspecific, alarms overwhelm true cases. A 99% false positive rate for that prediction. Continuous monitoring can raise C-sections by up to 63% without reducing cerebral palsy. In low-risk labor, pooled evidence found roughly 20% more cesareans. Yet, the same Cochrane review found neonatal seizures fell by half. The monitor is not useless. Its trade-off is sensitivity without specificity. Fetal distress remains the leading reason for C-sections in healthy pregnancies, diagnosed largely from CTG, because missing one true crisis can scar a child forever. Act early, and many mothers undergo unnecessary surgery. Wait too long, and one preventable oxygen injury may outweigh every previous false alarm. At civilization scale, safety systems often fail this way. Rare disasters force institutions to treat uncertainty as danger. Subscribe to CivilizationX as we examine the engineering choices hidden inside ordinary life. Google research models instead ingest fetal heart rate, contractions, and maternal metadata, then predict objective outcomes, such as arterial cord blood pH, a chemical record of oxygen deprivation. Convolutional networks scan short waveform shapes. Attention weighs key moments across labor, classifying CTG more accurately than human experts in some studies. In one 2025 study, combining clinicians with deep learning raised specificity from 91.92% to 98.03%, meaning far fewer healthy babies were falsely classified. But the combined system's overall discrimination was lower than clinicians alone. Better specificity on one dataset is not proof of safer births. Cleaner fetal ECG sensors may replace noisy ultrasound, but models must survive different hospitals, populations, devices, and rare emergencies without hiding false negatives. That matters globally. Wealthy hospitals may overtreat ambiguous signals, while clinics lacking trained interpreters or rapid surgery may miss genuine collapse. 5-year trials can test assistance, 10-year sensor gains may sharpen prediction. By 15, clinical outcomes must prove fewer injuries and unnecessary operations. That Sunday night, surgery delivered a vigorous baby with no evidence of oxygen deprivation. No single clinician failed. A system acted predictably under uncertainty. Her question remains medicine's. Can we clinically validate real-time monitoring that identifies which fetuses need immediate delivery and which alarming patterns are false alarms? The constraint is real. The data exists. Whether the systems built around it can act on it at scale, that is the next engineering problem. Stay with CivilizationX.